here with some of my I'm here with some of my colleagues and teammates who worked on this presentation. Um, so actually, I was planning for them to introduce themselves when they did their parts of the presentation, because this is not just a solo show. This is a group effort. But um, if you guys want to introduce yourselves, you can go ahead and turn on your cameras and say a little bit about yourselves. I'm a third year medical student. I'm interested in general surgery. But we do a little bit of everything here, and we're part of an organization which is trying to push medical education, not just for medical students, but also for high school students, and trying to reach out to disadvantaged communities on the island of Puerto Rico. So without further ado, I'll let the other group members introduce themselves.
Hello, can everybody hear me? Sure. Okay. So my name's Luis Garcia. I'm a third year medical student, also like Marcel Grau. Yeah, I'm interested in radiology.
Hi, my name is Amanda Morales. I'm also a third year medical student, and my interest is on adult neurology.
Hi, my name is Paulo Cruzado. I'm part of the group. I'm a third year medical student. I'm interested in PM&R.
Hi, good morning. My name is Javier Velez. I'm also a third year medical student with the group, and I'm interested in internal medicine.
And as I mentioned, we're all medical students from the UCSA, Universidad Central del Caribe in Bayamon, Puerto Rico. So we're very invested into trying to help the community in Puerto Rico reach better health outcomes. And we think that this is one of the avenues we can use to not only push for medical student education, but eventually use similar type of presentations on the island for high school students as well, in the public system and in the private system, wherever it may be necessary as well. So yeah, everyone, thank you for being here. We appreciate it, and we'll get started whenever we get the green light.
You are all good to get started.
Great, thank you.
Mm-hmm.
Okay, so you already pretty much know most of us. So our module today is going to be on cardiovascular complications in LHS plus patients, and we specifically want to discuss the specific factors that do affect Hispanic populations. We're going to go over different things such as like access to healthcare, specific disparity factors, and environmental as well as dietary factors. So I don't want to spoil everything because I think it's a very relevant conversation to have. But we're going to get started with the objectives for our presentation. Can everyone see the presentation?
Yes.
Thank you. Okay, so our objectives for today are basically to explain the epidemiology of cardiovascular disease, including key health statistics and specific trends. We also want to identify barriers that impact access to cardiovascular care and their implications on patient outcomes. And we want to explore culturally relevant nutritional practices and their role in cardiovascular health, as well as develop proficiency in conducting a culturally sensitive cardiovascular physical exam that takes into consideration specific factors within our target populations, which in this case would be LHS plus communities. So we're basically going to be dividing presentation into each one of us is going to present a couple slides. So I'm going to leave you off with our first presenter, which is Luis.
Hello, everybody. So we'll start off the presentation with our first question. If you guys can answer this question, what's the leading cause of death in the US for 100 years or a century? I think the title kind of gives it away, but if anyone can answer it. Well, if not, next slide, please. Surprise. So the leading cause of death in the US is cardiovascular disease. And so very interesting, a survey done by the American Heart Association done in November 2023 they found that only 49% of the respondents were able to identify cardiovascular disease or heart disease as the top cause of death, following cancer, and 60% were unsure of, the leading cause of death in the U.S. So it's very important because it's a need to raise awareness for people that are at risk, as well as not at being at risk for the cardiovascular disease. Next slide. Thank you. So basically, this is a comprehensive analysis done by the American Heart Association regarding the heart disease and stroke statistics in the US and globally. So it's basically a very important document because it basically summarizes or serves as a critical resource for people like professional healthcare professional policymakers, researchers, and for the public, um, detailing a lot of various cardiovascular conditions and much of their impacts. So a very important detail, and some of the key highlights from this from the update is that between 2017 and 2020, almost less than half of the uh, U.S. adults, specifically 127.9 million U.S. adults, were living with some form of cardiovascular disease. And following that, in 2021, cardiovascular disease was basically the underlying cause of almost a million deaths in the U.S., which basically alludes to the main question that I was trying to implement in the first slide, is that it's basically the nation's leading cause of death for 100 years, basically. And from another perspective, and it's very interesting the way that they put this, but basically they said that heart disease and stroke has claimed more lives in 2021 than all forms of cancer and chronic lower respiratory diseases combined. So it's the American Heart Associations were basically warning that there's a lack of awareness because basically nearly half of the U.S. population has some form of cardiovascular disease, which can translate, which this can translate to suffering from a lot of conditions under this wide array of health problems. Next slide, please. So a little bit about the Latino, Hispanic, and Spanish population. So in the U.S., between 2015 and 2018, more than half of Hispanic men and less than half of Hispanic women aged 20 years or and older were living with some form of cardiovascular disease, which is very concerning because they're basically applying young adults in this statistical population, right? So in this population, basically cardiovascular disease is among the leading cause of death for the majority in the United States. And the high prevalence and mortality rates of cardiovascular disease is basically significantly influenced by a lot of modifiable and non-modifiable risk factors. Basically, so in 2019, congestive heart disease was a leading cause of death, and basically it revealed that approximately like 15,000 Hispanic males and 10,000 Hispanic females suffered from congestive heart disease and died because of it. Meanwhile, stroke led to the deaths of 5,000 Hispanic males and 6,000 Hispanic females in the same year. So regarding risk factors, there's this very long-term study called the Hispanic Community Health Study, or the study of Latinos, which they found approximately 25 to 30% of participants exhibited hypertension. Meanwhile, the prevalence of diabetes in the same Hispanic population exceeded 12% higher, in which they compared that with the non-Hispanic white populations. And a very alarming statistic is that approximately 45% of Hispanic adults are considered or classified as obese. Next slide, please. On top of that, I think it's very important to talk about the economic impact of cardiovascular disease in the United States, because I think to me, it's considered part of the risk factors for people that can't afford proper healthcare in the United States. So regarding the financial burden, studies suggest that the combined direct and indirect cost of cardiovascular disease has exceeded $400 billion annually starting from 2020. And this included the costs like healthcare services, the medications, and lost productivity caused by death. And it's projected this cost is projected to increase by $1.8 trillion annually before 2015. So it's very important because this basically underlines the urgent need for robust preventive measures and innovative treatment strategies, policy initiatives to basically reduce both the human and economic toll of cardiovascular disease, not only on the Hispanic, Spanish, and Latin population, but also for all of populations, all of people.
Okay, now that we've covered that, we want to know what are some social determinants of health specifically that you think are involved in cardiovascular diseases. Can somebody participate or tell us about what they think?
Some social determinants of health may be education, socioeconomic status,
Yeah.
environmental factors, location, things like that.
Yeah, perfect. Okay. She covered almost all, but we're going to explain them even further. Some determinants of health specifically are lower income levels that are linked specifically to increased risk for cardiovascular diseases due to limited access to healthcare, poor nutrition, and higher stress. People with lower incomes often can't afford regular healthcare, and that leads to delayed diagnosis and poor management of conditions like high blood pressure and diabetes that are comorbidities to cardiovascular disease. Additionally, we also see how limited access to healthy foods leads to poor nutrition, which contributes to obesity and other risk factors. Chronic stress also from economic instability can raise blood pressure and promote unhealthy behaviors, further increasing the risk of cardiovascular diseases. And also, it has been noted how many Hispanics, which work in low-wage jobs, may have lack health insurance and also lack of paid sick leaves, limited their access to preventive health care. In another part, we have that educational level, as Caitlin also mentioned, shows how lower levels of education are strongly associated with reduced awareness of cardiovascular diseases or factors which can result in poor management of conditions like hypertension, diabetes, and hyperlipidemia, and how individuals with lower education attainment may have limited knowledge about the importance of regular health care checkups and the role of medications and the lifestyle changes required to maintain or manage these conditions effectively. Without proper education, people may not recognize the warning signs, specifically of serious cardiovascular issues, or understand in the long-term consequences of poorly controlled risk factors. It has also been noted how language barriers are a detrimental factor, such as limited English proficiency. As we may know, not everyone in the island are fluent in English, so that's a specific barrier that we have in our population. Also, language barriers in healthcare, such as miscommunications with doctors, lack of bilingual healthcare providers, or if they're not bilingual, we also have limited access to medical interpreters that we think that's a detrimental factor, because if our patient cannot understand the risk of their disease, how can they understand how to manage and how to treat them? There's also difficult understanding prescriptions and instructions to medications, health literally changes, and reliance on family members for translation that they may or not be medical advisors, so they cannot understand every little aspect of the patient's disease. There's also been studies of how economic factors also are involved in higher cardiovascular risk due to limited access, as I mentioned before, healthy foods, healthcare, and safe environments. Specifically, this economical strain contributes to chronic stress, leading or worsening cardiovascular risk. And there's different studies that show how household wealth is a strong predictor of cardiovascular outcomes. But additionally to that, there's also another study that shows how education is more important than wealth. And that's part of why are we doing this today, because it's important to educate our patients and other professionals in order for us to lower the predictor of how these patients are affected by cardiovascular diseases, specifically in low and middle income countries like Puerto Rico. There's also another circulatory study that shows that income and employment status are key determinants of cardiovascular health, and shows that low income, there's a 1.35 higher risk of cardiovascular or attaining cardiovascular diseases. And it also shows how employment, there's a 1.61 higher risk of also attaining cardiovascular diseases.
Hello. I'm gonna explain about barriers that can limit access to healthcare. If anybody wants to say one or two or what they might think, what is a barrier that's limiting the access to healthcare? If not, don't worry about it. Next slide, please. So, talking about access to healthcare, right? When I meant for a barrier, it means that something that's interfering patients that would need some proper medication or proper treatment, and because of so many factors that are affecting that pathway to get to healthcare, it's a huge problem. And I'm going to talk about that. So, for example, limited healthcare can lead to the diagnosis and treatment. Right, there's a delay. Many factors, for example, are like a lack of insurance, or the insurance is only restricted to certain areas. So that will lead to transportation barriers, because this institution may be so far away from where they're living, they have to find a way to get to there, and may be very economically huge for them. Or maybe they're not even in the state, so they have to go geographically, like in different states or different places, take a plane, take a train, or take the car, and it costs a lot of money and it will take a lot of time. So therefore, people will try to not do those things. They feel unmotivated and not safe, so it's going to limit their healthcare, and it will increase the risk. An example, right? Cardiovascular risk and incidence in for CVD. So 31% with these type of patients have this disadvantage, social disadvantage, will lead to higher cardiovascular risk. And next slide, please. So what are some barriers? Different factors, like people that don't speak English, they have a language barrier. They don't feel safe. They don't feel that they can communicate well with the provider. There's not language interpreters available, so it's not going to be efficient, that communication. And if, for example, they both understand English, but the provider doesn't give a good explanation of what is the jargon, right? The medical terms, it will confuse the patient, or the patient does not have the education to understand what's going on. Other is for absence of health insurance, right? It's very, there's a high cost. It's really restrictive for the patient to try to find a very good health insurance so they can have the best treatments available, and it will be very inefficient. And other is creating the lack of trust, right? Because the things that they don't accept the proper treatments, they don't give the best efficient treatments, they don't feel that the provider is giving them the best care because there's so many factors. They don't want to go to these institutions because they don't feel safe, so they're not going to say, you know what, I'm not going, because it's better off not even trying to find the best system available. So it's going to be very hard to like affect the patient's experience. It's not the expectation and the respect of the culture. They don't feel great for their culture. And next slide, please. So while researching the barriers, I found this article that is pretty interesting in 2017, where is in Minnesota healthcare programs, they found a survey for 2,194 adults where they feel discriminated or felt some barriers in their healthcare system. So, right, the demographic is 66% females, 76% high school graduates, 62% are unemployed, and 67% they live in the metro areas. So, what are the barriers they're most likely explored? They mentioned in this survey coverage issues. For example, they don't know what are their health plan is, and they don't know where to find the answers of their questions to which places they have their available their health insurance. Financial constraints, right? Because they're very worried if they have to pay a certain amount a month, their insurance is not going to cover that place, and it's very their medications might not even be available for them because there's a cost a lot of money. Access limitations, for example, they do not have the ability to get to the appointment. They do not know where to go. They have transportation problems, right? They cannot see their provider, so they're not even going to try to go there because it's too difficult for them. Family work obligations, for example, they have kids, they have work, and they can't risk taking one day off because they need the work, and it's going to be very difficult for them. And proper related challenges, for example, the languages, they don't understand their culture, they feel disrespected, religious beliefs, they don't feel trustworthy. Maybe unfair treatment because of assuming their gender, their ability to pay, their race, ethnicity, and their nationality. So the results, right? 29% they delayed their necessary medical care, 14% they found out before went to the care, and 24% they missed their preventive services. 14% compared to 29 and 24 is a huge amount. Next slide, please. Environmental influences that might affect air pollution, unsafe neighborhoods. They don't feel that safe that they can just leave the house and go to their provider, and that makes them not want to go to their provider. So it's going to cause, right, in this case, their cardiovascular risk. Maybe in their place they want to do some exercise, or they want to go to a gym or do some activities like sports. They can't because it's very limited. So therefore their physical activity and including their diet is going to affect, because it's going to increase the risk factors. Neighborhood conditions that doesn't allow them to do simple exercises as well, and the lack of green spaces, maybe walking their dog or going to a park, going to nature, like it's very difficult for them. So it's going to increase those rates, and though especially in those low income areas. So other aspects, right? Studies have shown that 29% with strong social support, like good communities, good neighbors, good family, improves their adherence, because they're going to tell these patients that, hey, you need to go to their doctor, you need to get these medical treatments, you need to keep working on that, and that improves a lot by 29%. Social isolation increases the risk, right, by 29%, and even strokes for 32%, because they don't have that social support. Stress, discrimination can elevate, your blood pressure, the diabetes and obesity rates in the minority groups. The diet, like food security, marital status, contributes to racial CVD disparities. And one of the things that they try to invest in making sure that it's going to help you improve your risk is community programs, access to healthy foods, have mental health support, and try to reduce stress the most they can.
Hi, everybody. So, what cultural factors do you guys think that can impact the cardiovascular disease?
Diet.
Anybody wanna?
Yeah.
Yeah, diet. That's a good
Yeah,
one.
diet, eating, cultural foods. Um, that's the main one I want to say. I also want to take a moment to just encourage the participants here. Please participate. Our presenters are doing an amazing job so far, so let's support them by being interactive, answering their questions. Thank you.
Of course. So, when we talk about cultural factors, we think about culture is the way that we think about everything. So it shapes how we think about health, including cardiovascular health. So many things, as Caitlin mentioned, like our dietary habits, our physical activity patterns, our beliefs about health per se, and the role of the family and the community. It's very important to us as physicians in training to understand these factors and promote better heart health for our patients, so we can have more effective prevention and treatment strategies. Next slide, please. So when we talk about dietary habits, we understand that different cultures have different diets. So a Mediterranean diet, for example, maybe have more an emphasis on whole foods, on healthy fats, on fresh produce, and lean proteins. Meanwhile, more like a Western diet could have a more emphasis on processed foods. So these foods may be higher in sugar, they may have unhealthy fats, preservatives, and they could lead to higher rates of obesity and chronic cardiovascular disease. Another important factor to mention is the portion size. So when we have a large family, traditionally, like, we encourage the dining experience to be an experience where all the family could sit down and have a large meal. So maybe sometimes this could lead to overconsumption in some cases. And alcohol consumption, right, it varies depending on different cultures. So some cultures like promote moderate drinking during dining, for example. For example, in the Mediterranean, you could try to have a wine while you have dinner. But some other cultures, they discourage it completely, or they prohibit it. And in that same line, some cultures and some religious, like, they have some certain traditions. So for example, they may practice fasting, or they may avoid some certain meats or some certain foods. So that is important to have in consideration when we're treating our patients, and we have a better understanding of what their nutrition consists of. And some other aspects is the social norms around food. So as I mentioned, like, some cultures, they emphasize eating as a bonding experience between their families and their friends. So it's important to understand that. And another factor, like, many of us, for example, I can tell you that as Latinos here in Puerto Rico, when we have some celebrations, everybody wants to go out, everybody wants to go eat, and this could lead to, like, overconsumption of food and alcohol as well. Next slide, please. So some of the factors affecting the physical activity patterns. Some cultures may have perceived barriers to the physical activity. So when we talk about socioeconomic factors, we can say that some families may have limited financial resources, so they can't have the same access to places where they could exercise, like gyms, or play some sort of recreational activities. Likewise, environmental factors could be a factor that could be affecting. For example, like lack of safe parks, sidewalks, or exercise facility that could discourage, like, physical activity. And also some norms, cultural norms, they may think like, oh, maybe exercise is not so important, so they don't have that as a priority as maybe some other cultures. And on the same line, some cultures could see like exercise up like an important part of life and health, while some others may think, oh, it's not really that important. It could be just something we could do on the side, and they don't prioritize that. And for example, another factor could be gender roles. So in some cultures, women experience less opportunities to exercise due to their social norms or safety concerns as well. Another factor could be work-related physical activity. So we can understand that some patients could have a more physically demanding job, so they have a labor-intensive job that could, provide somewhat of a built-in exercise. But we have also patients who they could have set, so they don't really have much physical activities, and they would require having giving more time to exercise on their own outside of their work. Community and family activities. So if a family could try to have some bonding experience over exercise, that could be something that could factor in as well on their physical activity patterns. Maybe some social and family involvement discourages us, so we have to be very aware of that at the moment that we're treating our patients. And another factor is the forms of exercises. So this is just an example. Tai Chi is a type of more meditative, slow-paced form of movement. Meanwhile, capoeira could be a dynamic of martial arts, dance, and music. So the type of traditional forms of exercise could vary between cultures. So we have to be very aware of that as well. Next slide, please. So there are different health beliefs and practices that we can face as physicians with our patients. So many patients could believe in a more traditional approach to medicine, but they could also be more modern approaches to medicine. So we have to be aware that some cultures may rely on herbal remedies, acupuncture, or spiritual healing rather than conventional medical treatment. So we have to be aware of that and not be dismissive at the time we are treating our patients. Fatalism and health perception. So some cultures believe that health is predetermined. So it could be like this is our fate or this is our destiny, and it's something that we have to be aware as physicians, and understand, because it could reduce motivation for preventive care or medical interventions. Another factor that could be a part of this is the mistrust in the healthcare system. So there could be skepticism to Western medicine, from past discrimination, from language barriers, or for concerns, right, about immigration status. Another factor could be spiritual and religious influence. So maybe some cultures they place some of their prayers and faith as a central role in their medical decisions. So it could influence their treatment choices. And another factor would be the idea that we have about body weight and health. So different cultures have an idea of what could be a healthy body size. So that varies differently between cultures. So we have to be aware of that as well.
Okay, so I'm going to be talking about the role family and community has on cardiovascular health. Firstly, there's certain collectivist family values and traditions which are strongly valued, which might influence dietary choices, exercise habits, and overall health behaviors, both negatively and positive. I think this goes over a little bit of what Javier mentioned in his part. There's specific practices like things like capoeira and things we do culturally that are encouraged that do impact positively in our healthcare systems, but there's also different cultures which, for example, place a high value on work. And if we work all the time, we don't have time for physical activities, and this might impact our health negatively. There's also many social stigmas around illnesses. And for example, in the Latino community, this sometimes comes across as when you get diagnosed with a certain illness, it's almost seen as a weakness. And I've seen this many times on the island. People would prefer to ignore many symptoms and would prefer to ignore very obvious signs of healthcare complications just because it gives them a certain self worth and an appearance amongst their peers of being healthy when they're really not, because sometimes it's actually seen as it's a weird dichotomy where we shouldn't see it that way, but sometimes it seems like, oh, you're sick, so now you have to miss time at work, and it goes down a rabbit hole pretty quickly. So it's very common, and I've seen this on the island, unfortunately, a lot of times. There's also differences in social support. Sometimes there are strong family ties, which can help encourage and discourage bad habits, but sometimes that is not present for everyone. As well as the community, it plays a huge role in giving us a support system that we can use to, for example, join a certain club or join a certain group that does certain activities, which again, everything is coming back to physical activity in our free time. And this is very highly impacted by everything we've kind of touched on already. Like, for example, if you're super busy at work, you don't have time to make for your physical activities, or if your culture doesn't prioritize it, you won't be as active. So that is a big contributing factor in not allowing us to have optimum health outcomes. Okay, so I also want to talk about the specific focuses that we want to have when we talk about what things we should pursue when we're eating. The emphasized foods are whole grains, fruits and vegetables, legumes and nuts, fish and poultry, moderate dairy products, and healthy vegetable oils. And the foods that we would discourage or at least advise to eat in less amounts would be refined grains, added sugars, trans fats, sugar-sweetened beverages, and red and processed meats. Again, this is where we go back to the specific cultural differences because, for example, the Mediterranean diet is a well-tested example of a diet that is very good for cardiovascular disease outcomes, as well. Also, things such as the DASH diet, which very heavily limits salt intake, is also something that is very recommended and very well accepted to be one of the first lines of treatment and prevention as well. So again, it all comes down to specific things that we eat with our specific groups. Okay, so I wanted to go over what we call the alternate health eating index, which is a composite score assessing nutrients and food groups and reflects overall diet quality. We looked at a graph about this, and it basically gives us a pretty detailed breakdown of what specific Latino populations have as this alternate health eating index. So what we see is when we have a higher alternate health eating index, we see lower risks of diabetes, cardiovascular disease, and metabolic syndromes. So going over this table very quickly, I know it might be a little small, maybe you can't see it all that well, but the main takeaways from this graph is that the AHEI score for Mexicans is the highest, indicating a best overall diet quality. So this means they have a more varied diet, and it's considered to be healthier when compared to other Latinos. When we look specifically at the Puerto Rican AHEI score, it's actually the lowest, which reflects the poorest overall diet quality, because we have a weird cultural mix of everything we eat here on the island. Most of it's fried food, and it's very delicious. It's great. It's fantastic. But we have that, and we also have the influx of American fast food chains, for example. So we have like the worst of both worlds, and this is a very, very preoccupying topic because it's easier to get those types of foods when you're going out of work, you're in rush, you need to eat something fast. It's easier to get that type of food, and also the food that we eat on our own houses is not specifically very healthy as well. So it's a very interesting case of multiple cultures blending in and contributing very negatively, unfortunately, to cardiovascular outcomes in our island.
Hey guys, it's me again. So what cultural factors can impact cardiovascular disease? What do you guys think? Wait, this is something we already discussed, but the question was like, what do you guys think was the importance of the physical exam and clinical practice? So I'm gonna go right ahead and talk about this. So you know, as physicians in training, the physical exam and the history taking is a very important part of our patient examination. So we have to take into account that maybe many patients come to us and they don't understand what's happening to them. They might be scared. They might be afraid. There might be some barriers, you know, to understanding what is exactly that they have. So a very important part of this patient encounter is mastering the cardiovascular physical exam. So when we use you know, a thorough cardiovascular exam, we can detect chronic issues that such as hypertension, heart failure, and valvular disease. So it when we are proficient in the physical exam, especially in the cardiovascular exam, we can demonstrate clinical competence to our patients, and you know, also establish rapport and confidence between the patient and the provider, so they feel they can understand what's happening to them, and they, you know, they don't have any type of questions during or after. They may have questions, but you know, it's our job as providers to make sure they understand everything, and we can empower them and they understand what's going on with the health and what they can do to make better decisions and to maintain their healthy lifestyle. Next slide, please. So the steps of the cardiovascular exam, this is very basic types of physical exam that we probably, or you guys could probably have already encountered in first year and second year of medical school. So I'm going to go over this real quick. So the first part is going to be inspection. So we're going to observe the chest wall for deformities or scar, visible pulsations, or any sign of cyanosis or clubbing. As we do this, we are going to be explaining to our patients what it is we're doing, so they can particularly understand what's going on, and they don't feel like it's something that we're doing that's invasive, or you know, it's just really so they can understand what is the purpose of this part of the physical exam as well as the other parts. And when we do this, we make a better relationship with our patients, and they are more empowered to understand their health. And then another part is the palpation. So we're going to feel for the apical impulse point and assess for thrills and heaves. That could be, you know, any indication of cardiovascular disease. And we also want to assess the patient's pulse at various locations to make sure it's uniform. As we know, when we have different pulses around our body, it could be an indication of atherosclerotic vascular disease. So that's something we want to take in consideration because it's something that has a high prevalence in our Latino communities. And the other part would be the auscultation. So we want to listen systematically of the key anatomic landmarks. So the aortic, the pulmonic, tricuspid, and the mitral areas. And we want to make sure that we use both the diagram and the bell of the stethoscope. Next slide, please. So, as I mentioned, when we are examining our patients, before we start the examination, we want to make sure that they feel comfortable in the environment, that they understand what's going to be happening during this encounter. So, some of the factors we have to explain, and we have to make sure that everybody is on the same page. One of the first one is the language. So, before we start, evaluating our patient, we have to understand if they're proficient in the language that we are currently speaking. It could be English, it could be Spanish, or whatever the language could be. So if we are speaking, for example, English, and the patient is not proficient in English, so we might have to have a translator there to be available and to explain every important aspect of the physical exam and all the findings. So that is very important to understand and to consider when having this examination. Another factor could be privacy. So we have to ensure patients that everything that they may be discussing with us is completely confidential. So they do not have to worry about anything that they may say that could be like detrimental to anything of of their current lives. So we make sure that everything is completely confidential. Likewise, we have we want to have an emphasis on having a private room, so the patient feels secure. They don't feel like they're being treated somewhere very public where everybody could see them. And we should also like ask before like we touch our patients or we examine our patients. We have to ask what is their preference, how much modesty they would like to have. So for example, it could be like if you're a male patient and you're attending a female patient, it could be like, oh, do you mind if I go inside your shirt, or would you rather me to go outside of your shirt? What would make you feel more comfortable? So that's some questions we have to make before we do our examination. Likewise, the positioning. Obviously, we don't want our patient to be uncomfortable during the examination, so make sure they are comfortable. And when we are speaking to our patients, we want to make sure that we are at the same level, of height, and we can establish eye-to-eye contact. So there's no making our patients feel bad or making them intimidated. And a very important aspect, right, of this is the communication. So we want to avoid medical jargons. We want to be clear and concise of what it is we're explaining to our patients, so they can, understand what each part of the examination is, and this could reduce anxiety during the intervention. And it just once again, it makes the patient. It empowers the patient so they understand what's going on and they can feel like a part of the medical treatment, and not just like, oh, I'm just receiving treatment, I don't know what's happening to me, but the doctor is treating me. We don't want that. We want the patient to understand, and maybe if some family member asks, they can have a clear explanation of what it is that they're currently facing with their health. So some of the considerations we have to have in Latino and Hispanic populations. So we have to understand that the prevalence of cardiovascular disease, for example, like hypertension, is high amongst the Hispanic and Latino patients. So this is, another key important fact. We have to prioritize the thorough cardiovascular exam, the physical exam, the history exam. So when we're taking our patient's history, so make sure what is the past family history. Do we have conditions like hypertension? Do we have any kidney disease? Is the type of things we want to make sure that we address during our encounter. And also helping our patient understand the importance of taking their blood pressure and how to do it effectively. And that is a way we can empower them to as an example, to understand more their health and what it is they're doing and what they're doing well and what they're doing wrong, so they can improve upon that. And likewise, very important, we want to engage in culturally appropriate discussion. So if we know that some things may not be like addressable for our patient because they stated from the beginning, they say like, doctor, like I don't want to eliminate the fried plains. We have to be understanding, and we have to work with that and try to reach a happy meeting with our patients so we can make a good patient encounter and ensure compliance and ensure that our patients are motivated to approach a healthier lifestyle. So this is our first case study question. So I'm going to read this question, and you guys try to figure out which one is the most appropriate next step in management. So we have a 56-year-old Latino man with a history of hypertension and type 2 diabetes mellitus that presents to the clinic for a follow-up. He reports occasional chest discomfort after meals and increasing fatigue over the past 3 months. His diet consists mainly of rice, beans, and fried plains and red meats, with frequent consumption of sugary drinks. He has a sedentary lifestyle and limited access to healthcare due to work hours. On his vital signs, we have a blood pressure of 152 over 94. His heart rate is 88, and his BMI is 32. A physical exam, we have an S4 heart sound, mild pedal edema, and decreased breath sounds at the lung basis. And the ECG shows left ventricular hypertrophy. So, which of the following is the most appropriate next step in management? We have A, start a beta blocker. B, order a fasting lipid panel. C, recommend a culturally tailored diet modification. D, perform a stress test. Or E, prescribe a low dose aspirin. So what do you guys think could be the appropriate next step in management? We got C over here. C is a good guess. Anyone else? All right, so we can go to the next slide. So actually our answer in this case would be B, order a fasting lipid panel. And could we go to the next slide? So the reason why ordering a fasting lipid panel, we want to do that first because in this patient, it has a history of diabetes, of hypertension, and obesity. So he has an increased risk of atherosclerosis, cardiovascular disease. So we first want to understand what his risk factors are and what specific measures we could do to him to help our patient. So once we have our lipid panel, we can assess his eligibility for statins. So once we have, the lipid panel assessed, if the patient has, a normal lipid panel, we could recommend lifestyle changes, like, that was one of the answer choices. But before we can do that, we need to understand how our patient is currently doing with their lipid with their lipids. So because if they have, values that are too elevated, maybe lifestyle changes could, be an important factor, but they could not completely address the issue. And likewise, aspirin should not be a first step in primary prevention of cardiovascular disease in this case. And, once again, the changes in lifestyle are important, but we have to stratify the risk to understand where our patient currently is and what we want to do with our patient to avoid further complications.
Oops. Let me go back. Oh, I kind of spoiled it. Sorry about that. So we're going to start discussing our second case, which I kind of already spoiled. But our case is a 62-year-old Spanish-speaking Latino man with a history of hypertension and type 2 diabetes, who presents to the emergency department with progressive shortness of breath and lower extremity swelling for the past 2 weeks. His primary care follow-ups have been inconsistent due to difficulty scheduling appointments and lack of Spanish-speaking proficient providers in his area. His medications include lisinopril, metformin, but he admits to missing doses because he cannot read the instructions on the bottles. His vitals show a blood pressure of 160 over 95, heart rate of 98, and respiratory rate of 22. Physical exam reveals bivascular crackles and +2 pitting edema in both legs. Which of the following interventions would most effectively address patient barriers to care? Option A, increases the lisinopril dose. Option B, provide discharge instructions with a medical interpreter. Option C, refer to a specialist for further cardiac workup. Option D, prescribe a new medication with easier dosing. Or option E, encourage lifestyle modifications and weight loss. So I kind of already spoiled it, but if anyone wants to chime in, if they didn't see the spoiler. All right, I think we got a B in chat. So yeah, it would be B, because in this example, it's basically a very cut and dry case of someone who doesn't have the healthcare literacy and English speaking proficiency necessary to navigate the medical field. So not only a patient like this would have problem getting appointments, they would also have problems reading the specific instructions for the medications. So there are many efforts going on to try to fix these issues. There are efforts that try to hand out instructions which are bilingual in many places, but these efforts are not the standard in many places. So this would definitely be an issue that we would want to address by providing instructions with a medical interpreter or instructions in English and Spanish or whatever the specific language of the person would be. And this would preferably be in a case-by-case basis, but there should be standards set into place where we can have a patient goes to a specific, for example, drugstore, and they could identify their language and they could get a tailored instruction packet on how to use their medications. Because as we see, literacy in the language means that the adherence to care, it's basically one-to-one. Good adherence to care comes when we have good proficiency in the language and good healthcare literacy. So there are many things we can do, and one of the first steps that we can do is use a medical interpreter and a specific set of instructions that are tailored to the language of the speaking person. The other options pretty much would go in line, would be correct if this wasn't a specific issue of English literacy. And that's basically it. And those are our references. I don't know if anyone has any questions or any recommendations, but I wanted to thank you all for listening to our presentation. We appreciated you coming out this early on a Saturday morning. So thank you for everyone for listening, and thank you to all my fellow presenters for also being here and sharing this with you.